Hello, I'm Dr. Obey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, it's time for sharing and caring once again, that we share our med moments and we care about each other. Remember, go see your doctor. Obey your doctor. Remember my website, obeyyourdoctor.com. And you can hit me up on Facebook now and get health tips. And we're doing a lot of things with health on Facebook. So, Obey with a space, your with a space, doctor. That's for Facebook. Alrighty, we're going to talk about a topic tonight, and it's a very important topic. We're going to talk about premature labor and delivery. And I have an excellent physician to talk about this particular problem, Dr. Yvonne Wright-Cadet, and she's an obstetrician gynecologist. Welcome to our show.
Thank you.
Welcome.
It's great to be here.
All righty. So this is your return. This is a return trip for you. So
Yes.
you're an old hat at this now. All right then. So I really want to talk about this topic because I know it's such an important topic. So let's start with my favorite question. What is premature labor and delivery?
Well, it's good to be here again, Dr. Bey. And the pregnancy lasts for 40 weeks.
Right.
We consider a term pregnancy any pregnancy that ends at 38 weeks. That means 2 weeks before your delivery date.
Okay.
If a woman delivers before that, it's considered preterm.
Okay. All right.
So we go by the date that you're due and how many weeks earlier that you deliver.
Okay. All righty. I'm just going to get some definitions out of the way.
Sure.
What's a contraction?
A contraction is the uterine wall, which is made of muscle, squeezing.
Okay.
Simple as that.
Simple as that.
If you lift a barbell, your muscle contracts. The same thing the uterus does, and that's just a contraction.
Is it like a spasm?
That is a very interesting question. Some women describe it as spasms, some women describe it as menstrual cramps, and women who've had babies before just describe it as pain.
Okay, pain. That was my next question. Do all contractions hurt?
There are certain contractions that do not hurt.
Okay.
Usually those are called Braxton Hicks or false contractions. So they happen during the last trimester of the pregnancy, and some women just feel a tightness of her uterus or her abdomen, and those are not painful.
Okay.
When they become painful, then we tend to call them contractions or labor pains.
Okay. Just some anatomy. The uterus, the cervix, kind of explain how that is aligned and what happens there during pregnancy. Not during, but you understand where they are and
Sure.
that what's carrying the baby.
Right. Women have a unique organ called the uterus or womb, and that's in her pelvis. It is at the top of the vagina. So the uterus is a little cavity. Within the cavity, the baby will live. At the bottom of that cavity is a cervix. That organ is a part of the uterus, but it's made a little differently, and it holds the uterine cavity closed so that the baby during the pregnancy stays inside and can't just slip out.
Okay. So when the baby is delivered, it's going to come through the cervix?
That's correct.
Okay.
The cervix is closed in the beginning. Labor makes that cervix open up where the baby can now come through.
Okay. All right then. Okay.
Some people call the cervix the neck of the womb.
Okay. All right then. Premature labor and preterm delivery, is that the same or are they different things?
Well, when the uterus starts contracting early, that's called premature labor.
Okay.
Then that's the uterus contracting anywhere before 38 weeks when it basically should not.
Okay.
The delivery part is called preterm delivery. Doctors now can try to intervene and stop those contractions. So if we successfully stop those contractions, then we say that we've stopped your preterm labor to prevent you from delivering early.
Okay, so delivery is actually the baby coming through the canal and coming out.
Correct.
Alrighty, and the contractions is the muscle actually contracting, trying to push the baby out, basically.
Exactly.
Okay, all right then, we got that down. At what point during, well, you already answered this question. I think at what point during the pregnancy do you define it as premature? And you said that was
before 38 weeks.
Mm-hmm. Now, is there a time that it's too early in the pregnancy to determine, to call it premature? Is it, you know what I mean? You understand what I'm saying?
There's an area at around 20 weeks when anything before that we consider, if you go into labor early, a miscarriage, because the baby really has no ability to live outside.
Okay.
No ability at all. No ability to breathe, pump blood properly, etc. Between 20 to 24 weeks, that is a very difficult time period, because we're not 100% sure when the baby gets to the point where it can live. 24 weeks, we try to do everything we can, because 24 weeks and after, the baby can live.
Okay.
It may be premature, it may have some difficulties in life, it may not develop 100% normally, but the baby can survive.
Okay, all right.
They don't all survive, but they can. So 24 weeks up to 38 weeks or 37 completed weeks, that is a time period that is called a premature baby.
Okay.
So 24 weeks to 38 weeks is a premature baby. Anything between 20 to 24, we're not sure whether the baby can live. Under 20, the baby cannot live.
Okay. Fetal growth, as far as, well, a fetus, explain a fetus. Let's go there.
Okay.
So we have the definitions and we all know what we're talking about.
A fetus is considered a human form that's developing.
Okay.
Before a certain time, where we're not sure whether the baby's alive or not, it's called an embryo. Egg and sperm meet. They're not in the uterus. They travel down the tube. They get into the womb and implant. Once that implantation occurs and we start developing a fetus, developing a human form, that's a fetus.
That's a fetus at that time.
And we don't call a fetus anything else until it comes out, then it's a baby.
Then it's a baby. Okay, okay. So as long as it's in the mother and it's growing, it's a fetus. It's not a baby yet until it's delivered.
Correct.
Okay. Now, the fetal growth, is there a certain chart that you should follow, or it should grow at a certain rate?
Sure.
And if it's preterm, does it usually, is that growth usually inhibited with preterm babies?
Well,
or fetus?
Fetus, right. Well, we can call it a baby.
All
you know,
right.
mothers call that growing person in their baby.
A baby, all right.
Yeah, we call it fetuses. When we measure the progression of a pregnancy by a couple of things, by the ability of the organs to function, and then one of the other crucial things that we use from the outside is a growth curve or a growth chart.
Okay.
Just like when you take your child to a pediatrician, they measure the baby and there should be a curve. We do the same thing with a fetus. Okay. So every trimester, we can map what the average growth is and whether the mother's fetus or baby is above and below. And that just tells us how well the baby's growing.
Okay.
There's one weight that for us helps define whether this baby would be able to live outside, and that's 500 grams, which is a little over a pound.
Okay.
So when we get to that pound, and that's usually around over 20 weeks, that is a crucial number. So when the doctor tells you your baby's over a pound, then we're kind of moving toward a baby that can live outside.
Okay, all right. How do you know how large the baby is during the pregnancy?
This wonderful thing called sonography. The good thing about sonography is that there's no radiation or x-rays to hurt the baby. It works on sound waves. Right. So mothers can be very happy. That's a very safe way to check the baby. And they actually measure 3 things on the baby. One is the length of the thigh bone.
Okay.
The other thing is the width around the abdomen. And the third thing is the head circumference. And they put that into a little algorithm in the machine, and it comes up with weight.
Okay, so you said the thigh bone?
Thigh bone,
the
abdomen.
Abdomen is around your tummy area.
That's right, the abdominal circumference, and then the head circumference.
Circumference means how the total
the distance around
the head.
Right. When mothers will understand that. When they go to the doctor measures the baby's head with a little tape measure.
Right. That's called the circumference.
Circumference. And women know that because we're always measuring our waist.
Right.
So that's the same idea. They measure all around the baby's abdomen, and they use those 3 numbers, and they can tell you how much the baby weighs by sonography without a scale.
Okay. Let's talk about premature labor.
Okay.
If a baby is small for the amount of weeks that it's been in the incubator, does that increase the chance for the mother going into labor early?
Right. You're talking about something called growth restriction. Okay. So when we measure the baby and the baby does not fall in the right weight, it's called growth restricted. That means the fetus is not growing well.
Okay.
Sometimes that does increase your risk for premature labor.
Okay.
And because the baby, for whatever reason, it could be from malnutrition from the placenta, not getting enough nutrition. It could be because the baby has some type of problem or infection. It could be because the baby's genes are not normal. We all heard of Down syndrome babies. Sometimes they don't grow well. So when the baby does not grow well, we say that the growth is restricted, and then that makes us look for reasons for that, infection, other causes. And sometimes those babies do go into labor early.
Okay. What's the normal, I know there's probably a range, but what's the normal rate for a normal baby at delivery?
It goes up with the number of babies you have, but the average is about 7 to 8 pounds.
Okay.
That's what your baby should weigh, about the weight at delivery. Now, we deliver plenty of 6-pound babies who are perfectly healthy and normal, and we deliver 9 and a half, 10-pound babies that are healthy. So the average is 7 to 8, but the range is very wide. 6 to 9 and a half is normal.
Okay. Are preterm births increasing in the United States at this particular point, or are we at a point in medicine that we're really conquering this problem?
Yeah, there's a number of factors that affect preterm labor. In different populations, it's different. Okay. It's a small percentage overall in first world countries like the United States. Right. So we have better health care, better access to care, mothers are well nourished. So in our country, it's not that great a number.
Right.
It's probably maybe 5% of all people who actually deliver preterm.
Right.
That is different from the people who go into labor early. There are many more people who go into labor early, but we have the technology and the medicine to stop those labors.
I got you.
So maybe 20% or less may have some type of preterm labor, but only maybe 5% of those people actually deliver.
I got you.
In other countries, it's worse.
It's worse.
And those babies don't survive as well because we don't have the ICU and the technology to keep them alive.
Right, right. Let's talk about twins and triplets, because that does happen every once in a while. Are they at greater risk for delivering early?
Yes. Twins, if the average for a normal single baby to deliver around 38 weeks or later, twins tend to deliver around 36 weeks.
Oh, okay.
And that is considered for them normal.
Oh.
We don't try to stop a 36-week twin pregnancy from delivering if the lady goes into labor. Matter of fact, we're happy because they are at higher risk to deliver much earlier than that. Okay. So they may deliver at 32 weeks, and that's considered preterm. 34 weeks, that's preterm. 36 weeks, we're happy for twins. Triplets deliver even earlier. They may deliver at 34 weeks or 32 weeks. Oh. And we're almost happy about that because they have such a high risk of delivering early. Okay. 32 weeks for triplets, 36 weeks for twins, and of course 38 weeks for a single baby.
Do you think it's because the uterus has such a heavier load in it that's weighing down and
the more the uterus is distended, or the more contents that the uterus has, the tighter the wall is, the more increased risk for those contractions to occur. Okay. Even if it's a single baby, if there's too much fluid, because some women have a problem with excess fluid when you only have one baby, just that excess fluid increases the risk of preterm labor. Right. So yes, anything that swells the uterus or makes it distends more increases the risk.
Okay, okay. What about as far as preterm? At what point during the labor, during the pregnancy, is increased risk of death to the baby because they came early? You understand what I'm saying?
The risk has to do with how many weeks pregnant you are. Okay. So anything under 24 weeks, the risk of death is very high. After 24 to probably 28 weeks, the risk of death is probably around 30 to 40%. Okay. But because of our technology, we can keep those babies alive for longer. And after 28 weeks, the risk of death goes down markedly because 28 weeks, the baby's organs tend to now be able to function better. Right. So with ICU care, those babies, maybe you may have a 20% rate of the baby not living, but 80% living. So as the number of weeks increases, the risk of death decreases. Okay.
What are some of the structural abnormalities that the mother may have that may cause preterm labor?
Yes, there's two things for structure. One we talked about earlier, the uterus itself, the uterine wall, and the cervix. So
Okay.
both of them have different functions.
Okay.
The cervix itself is made out of fibers that are made to stay closed until something in our body triggers them to start loosening up and distending and opening.
Okay.
There is a disease called incompetent cervix. And that occurs during the early part of the pregnancy when as the weight of the pregnancy increases, the cervical fibers can't hold. They start dilating and loosening up early. And usually we see people losing babies 22 weeks or less because of this problem. We are not 100% sure what causes it.
Okay.
We know that there's something about those fibers, enzymes don't hold, and they just start breaking down. And we usually find out about this when someone loses a baby, out of the blue. They can't feel it. They don't have contractions. The weight of the pregnancy just pushes the cervix open. And then they come to the hospital with the cervix dilated because all of a sudden they'll start feeling something like water coming out. So they may break their water early. So that's one anatomical problem that women have. It's incompetent cervix. It's not very common, but there are risk factors for it.
Okay.
Multiple pregnancy losses, that's one risk factor. Multiple termination of pregnancies, because something damages the cervix with a termination. And if you've had more than 3, you're at risk. We're even worried about 2 now. 2 terminations can increase your risk for cervical incompetence.
Oh.
The
That's the cervix not working
The cervix
properly.
not working well.
Right.
It just, the walls don't hold together and it just opens spontaneously from pressure. The other thing that can cause preterm labor is the uterus not being normal. Some people are born with a uterus that has problems with the walls not being smooth and round. Most uteruses are round or shaped like a pear, but the walls are smooth and even. Some uteruses are heart-shaped, so instead of being smooth at the top, there's a little indentation like a heart. And that defect in the wall or that change in the wall can make the walls not be able to hold a full-term pregnancy. And that can cause a problem with preterm labor. Some people are actually born with 2 uteruses. And if the baby is in one, it's not as big as one whole uterus, that baby may be born early because it's in a smaller cavity. It just can't grow. And finally, the uterine wall says, oh, this is too much, and starts contracting. And that's a risk for preterm labor.
Okay. 2 things. The baby is in the uterus. Is there a sac that the fluid is in? You talk about
breaking the
water.
Yeah.
Is it, yeah,
Yeah,
it's a term that we all know, but give me
What does that mean?
What does it mean?
When the baby implants in the uterine wall, the embryo implants and turns into a fetus, it develops a sac called an amniotic sac.
Okay.
And that sac it's sort of pasted up against the wall of the uterus. It's actually there's a seal.
Right.
And the baby is actually inside that. So the placenta is in the mother's wall, and the baby is in this sac, has an umbilical cord that connects to the placenta. So the baby has its own little swimming pool.
Okay.
It's sealed. Nothing can get in it except what comes to the baby through the amniotic, through the umbilical cord.
Okay.
And all that fluid, guess what that is? Urine. The baby urinates, sterile urine, no bacteria, to fill that sac up.
Right.
And that's where the baby lives for that 9 months.
Oh my goodness. All righty.
Separated from the world.
Okay.
And happy.
Fibroids.
Yes.
Can you have premature contractions secondary to fibroids?
Yes, I'm glad you mentioned that. I didn't bring that up. I was thinking another genetics.
No, that's fine.
Yes, there are tumors, these little tumors that grow in the uterus called fibroids. And actually in African American women, we have a very high percentage of women with fibroids. About 30% of African American women have fibroids. That is a huge number.
Right.
They're not all very large, but if they're in the wall of the uterus and they get inflamed, they can actually irritate the uterine wall and cause it to contract early. They can also grow into the cavity. So if you have these big tumors in the cavity, they take up some of the space, and the baby and now these fibroids cause the uterus to be more distended, and that can cause the uterus to contract early.
Interesting.
Yes, so fibroids are another cause of preterm labor.
All righty. If a baby comes early, some of the things that we have to worry about as far as the baby is concerned and the likelihood that it'll live, the respiratory system and the eyes. Tell us about that a little bit, and maybe how do you handle it, you know, delivering it, and what happens to the baby to make sure that they're...
After 24 weeks, we think that the organs can function outside, but they don't function well. So one of the primary things that any human being needs to live, the first and most important thing is oxygen, and that's the lungs. And inside the body, when the baby is connected to the placenta, the baby gets all the oxygen and nutrients from the umbilical cord and the placenta through the mom's eating and breathing. Once the baby's out, those organs have to work. So after 24 weeks, we think that the lungs are the primary problem for babies. So we try to give things to help with that. We can give steroids to the mother, injections to try to see if that can get into the lungs of the baby through the placenta and the umbilical cord to help the baby's lungs to mature a little more quickly. That is the only thing we have that we can treat the mother with. The eyes don't work very well. The brain is not mature yet. The kidneys don't necessarily work well. But we don't have the technology to do anything about that. The only thing we can affect right now is the lungs.
It's the lung.
Once the baby's born, then we see what works. You test the baby's urine to see if the baby can urinate. That tells you the kidneys are working. You can do some tests on the eyes, but that's not the most important thing in the beginning because you're just trying to keep the baby alive if it's really premature. You try to give the baby tests on the, not tests, but you monitor the brain because the baby's blood vessels are very weak and the brain can actually bleed spontaneously. So the brain can bleed, and we can do scans to check the baby's brain. So when the baby comes out, depending on how mature it is, we test the organs to see what they can do. The baby's usually in the ICU for weeks to months, depending on how early. And with the ICU in this country, sometimes babies at 24 to 25 weeks can live and do pretty well. After 28 weeks, we find that babies' organs are much more mature. Now, we're talking 28 weeks. That's 3 months before your due date. And even those babies survive. So the ICU is really critical to, if you think you're in labor early, is to get to your hospital. So that if you deliver, well, number one, so we can try to stop the delivery. And number two, if you deliver, you can have the best care with the ICU and the neonatologist immediately.
Those are the specialists in the ICU. Neonatologist is the specialist in the ICU that take care of babies.
Exactly.
All right. What about race? Is race a factor with preterm?
We think race is a factor for preterm labor, but more the socioeconomic part of it. So socioeconomic status, we think, so a poor, not well taken care of African American woman, or a Hispanic woman, or Caucasian woman, all of them, because of the lack of care and general health, are at higher risk. There probably is a small percentage that increase with African Americans that we don't know the cause for. But we think mostly is lack of care, lack of general health, and nutrition is more risk than just race. What
about the mother's age? Is that a factor? Too young or too old?
We do see that teen mothers tend to have higher risk of preterm labor. We think most of it is because of lack of general health care. On the other spectrum, older women who are well off, well nourished, they have something else that causes them to have an increased risk of preterm labor. It may be just that the placenta in an older woman is not as healthy. So it's not feeding that baby well, and something triggers in that body to cause that baby to deliver early. That is a topic of research. We're not sure about that. But what we do for both extremes of age is to monitor the patients very carefully, make sure they have adequate health care, adequate nutrition, vitamins, and then we can see the preterm labor coming before the person delivers. That's the preventative care part of it that your show talks about so much. Seeing your doctor and getting monitored and having the education. If you feel something, contractions or something that doesn't feel right, you ask your doctor, what's the next step?
Genes. If your mother had problems with her pregnancy, is it likely that the daughter, when she gets pregnant, will she have problems?
That probably has to do more with the genetic aspects of it. Like having fibroids. We know that if your mother has fibroids, you're higher risk. If your family members, your mom, sisters have this problem with the cervix, incompetent cervix, you may have it. So for those risk factors, yes. For your general health. If your parents are low income and do not have access to care, and you don't, you're at risk for the same problems they had.
Right. Smoking. It's a big issue throughout the country. Does that affect the baby and preterm and delivering early?
Smoking has a couple of problems for the mother and the fetus.
Okay.
Mostly women who smoke are at high risk for preterm labor. We think it may be related to the placenta not functioning well in smokers.
Right.
So that means if the placenta is not functioning well, your baby tends to be smaller, and you have another risk factor for preterm labor. So yes, smoking in general is bad for pregnancy, health in general, but pregnancy for sure. We find that women tend to be able to stop smoking more when they're pregnant than any other time, because there's something about the fetus.
Right.
So responsible women, usually you can get them to stop smoking for pregnancy if you try.
Interesting. What about stress? Now, with our society now, and you know, everybody's working 24/7. What about stress in pregnancy?
Not sure. Not sure. We do not know if stress increases the risk of preterm labor. We know it increases adrenaline in your body. And for example, a lot of people know healthcare workers who are stressed. OBGYNs may have a slightly higher risk for preterm delivery, but people in other areas, other types of stress may also. That is still out. That we're not clear about that yet.
Right. We're almost at the end, and I just have to ask about things like sexually transmitted diseases and multiple partners. We're going to wrap it up.
Okay. Risk for pregnancy in general, or just?
Well, as far as preterm and
okay.
yeah,
right.
you know.
When early in the pregnancy, by 12 weeks, the cervix developed this thing called a mucus plug. That tends to decrease the risk of anything like gonorrhea or chlamydia getting into the uterine cavity.
Right.
There are other diseases like HIV, herpes. Those things don't necessarily increase your risk for preterm labor.
Right.
But that's early on in the pregnancy. Toward the end of the pregnancy, there are other infections, not STDs, parvovirus, certain diseases that get into the bloodstream can increase your risk of preterm labor.
Okay, we're going to have to end right there, and it was a great discussion.
Thank you.
Thank you very much for coming on. It was great.
Pleasure.
And I'm Dr. Omar Bey, and remember, this is a moment in medicine. Do not change anything in your medical care until you consult your physician. Until next time, thank you. Peace to you all.